A very pleasant good evening to everyone here. I am Dr. Nishant, Cornea and Refractive Surgeon, MNI Hospital. Today is actually a very special day, not only for the lucky listeners who are listening to this amazing talk, but also for me. Dr. Mohan Rajan sir has always been generous with his words and his love for introducing me. And now finally, it is payback time, sir. I thank Johnson & Johnson for actually organizing this amazing session of almost around, this is the fifth important talk which is there among their series of 7 series. So you have 2 more interesting series. Please do not miss each and every single one of them. Everyone will say this man needs no introduction, but I will say he is someone who definitely needs a great introduction. I think Johnson & Johnson might have to organize a whole session about the greatness Dr. Mohan Rajan sir has achieved as an ophthalmologist. He's helped young ophthalmologists like me to have a great passion for this field and as humble, kind, and ever-loving person. He's a doyen in ophthalmology, national and internationally. And more than all his greatest achievement, he's actually like a godfather to me and my family. He is the chairman and clinic medical director of Rajan Eye Hospital in Chennai, Tamil Nadu. He is also the president-elect of Tamil Nadu Ophthalmic Association. He's been the past president in IIRSI and past secretary in MCOA. He's authorized in numerous books and he's also chaired several symposias. His talks is one of the most attended talks nationally and internationally. And not to forget, he's actually won more than 50 Best Entertainment Award videos in the OPL. And that is something which I'm trying to catch up, sir.
Thank you.
He's performed more than 30 live surgeries and he's performed more than 1 lakh of cataract surgeries and vitreoretinal surgeries. It's a pleasure having you, sir. Thank you so much, Johnson & Johnson, for making Dr. Mohan Rajan, sir, talk to us. Over to you, sir.
Thank you, Nishant. Shall I share my screen now?
Yes, sir.
Okay. Are you able to see my screen?
Yes, sir.
Okay. Good afternoon, namaste, and let me at the outset thank J&J for this wonderful opportunity. This has been really a fantastic experience, learning experience for me also. The Phaco Masterclass series is the 5th of its kind, and we have had 4 series in the past 4 weeks, and it's been very useful. I've got getting a lot of feedback, and people have really commended this wonderful work which has been done by J&J. Also thank Nishant, my very, very good friend. Both Nishant and Nivian are my 2 eyes, I would say, the right eye and the left eye. And there may be 2 children for Madhi and Shalini, but these 2 guys have really, what you call, they are the blue-eyed boys, in my opinion. They're really fantastic. Guru ku minjiya sishyan solvanga. That is the, I think, way Nishant and Nivian have grown up and taken MNI Hospital to a different level. I'm very, very proud of them. And I played a very small role in their career, I would say. Encouraged them to both national and international conferences. And it is only because of their own effort and own competence they come up to this level. Thank you, Nishant, for the wonderful introduction. I'm always grateful to your family and to your dad and mom for whatever we are here today. Phaco Masterclass series. The first one, I talked about know your Phaco mission. The second one, we talked about wound construction. Third one, we talked about capsulorhexis and hydro procedures, which in my opinion is one of the most important steps. Then last week, we talked about nucleus management. So after knowing all this, then you come to the final stage of the phacoemulsification before you put the lens. That is the epinucleus and cortical aspiration tips and tricks. And that is what I'm going to talk to you about, this important step in the next few minutes. Now, let us understand stages at which the PC rupture can occur. During hydrodissection, during nucleus removal, during cortex removal, during posterior capsule vacuuming, during IOL implantation. But the most important step by the cortex removal, at that time only the PC rupture, the incidence of PC rupture is very high. The reason is that very high vacuums are used to remove the cortex, and the posterior capsule is not protected. When you are doing the nucleus removal, the epinucleus protects the posterior capsule, so you are against a very high vacuum. Whereas when you are doing the cortex removal, if you are not very careful, if you are very complacent, and if you are not very good on your foot switch, you can rupture the PC within a millisecond. And that's what is very important. At that time, the cortex removal is very important. Let us see this video. You can see this. I'm doing a BIMANNUAL IA. This is an old video. Now watch this video very carefully. I'm trying to remove that cortex there. I'm using a BIMANNUAL IA. You can see this. As I'm doing that, I'm trying to catch the posterior end of the fiber. You can see what's happening. The posterior end of the cortical fiber. The cortical fiber has got anterior as well as the posterior end. If you try to catch the posterior end, within no time you can rupture the PC, especially the PC is much thinner than the anterior capsule. You can rupture the PC. You can see what happens. PC rupture, and you are in trouble there. Now, epinucleus and cortex removal, the most important, as I told you, the highest incidence of posterior capsule rupture, especially for beginners during this procedure. And you have to be very, very careful. Also, even for the veterans, I would say, because the cortex removal, you are a little complacent. At that time, your concentration is not 100%, like the capsulorhexis or the wound constriction or the nucleus management. You're not very confident at that time. You're not very concentrating too much on that time, and you're likely to make mistakes. And this mistake can be very, very, very serious mistake, like a PCR at that time, and the vitreous can start coming into the anterior chamber. Epinucleus management, you can have, first I'm talking about the epinucleus management, and then I will talk about the cortical management. The outer nucleus shell, if you do a hydrodissection, which I normally do, I don't do hydrodelineation. We talked about it in the class 3, wherein we are talking about the hydro procedures. There are 3 conditions wherein I will do only hydrodelineation. That is posterior polar cataract, traumatic cataract, and post-vitrectomy cataracts. As you know, sorry. In hydrodissection, it separates the capsule from the rest of the lens. Why I am doing hydrodissection is that if I do a hydrodissection, then I don't have an epinucleus in hand. When I do remove the epinucleus from the nucleus, the epinucleus also comes along with that, because I don't separate the epi from the endo. If you do a hydrodelineation or a hydrodemarcation, all the same, separates the epinucleus from the endonucleus. Sometimes in softer cataracts, you might have to do. In harder cataracts, there is no epinucleus at all, brown cataracts. So if you separate the epinucleus from the endonucleus, then you will end up, after removing the nucleus, you will have an epinucleus shell there, which may be a little more difficult to remove. So you can see the video on the left side. You can see here I'm doing an hydrodissection in a soft cataract. And then you can see here in this one, I'm doing a hydrodelineation. So the picture on the left side, when I remove the nucleus, the epinucleus also comes along with that. Whereas the picture on the right side, when I remove the nucleus, what will happen? The epinucleus is there still. So you will end up in doing an epinucleus removal, and many surgeons don't, especially when you gain experience, you don't. For example, this is the patient with a hard brown cataract. As I'm doing this, we are talking about this nucleus management last week, how to do the direct chop technique with the sharp chopper, the vertical chop, all that is the out of scope of this lecture. But if you see that as I'm trying to remove the cataract, the whole cataract is coming out. This is a very hard brown cataract, grade 4, grade 5. And you can see here, as I'm removing the nucleus, because there is no epinucleus, I didn't do a hydrodelineation. Can't do an hydrodelineation. Because this nucleus is and more nucleus, very difficult to separate the epinucleus from the endonucleus. And you can see here, as I'm removing the nucleus, what is happening? The epinucleus is also coming along with that. You can see that at the end of the procedure, okay, you have to be a little careful. You have to reduce the parameters when you're removing the last piece there. Otherwise, you can hit the posterior capsule. You can see that absolutely the capsular bag is empty. There is no epinucleus, there is no cortex also. Because these are all nuclear cataracts, you have to be very careful. Okay? But the advantage is that you don't have an epinucleus. So the nucleus and the epinucleus comes along with that. So surgeons like me, what we do is we do only hydrodissection. We do a cortical cleaving hydrodissection and separate the nucleus from the rest of the capsule, that is the rest of the lens. And then rotate the nucleus, do a chop technique, remove the nucleus and the epinucleus. Towards the last piece, you have to be a little careful, especially when you're using a peristaltic system. And you have to be, even if you're using higher end machine, always reduce the parameters. We talked about in the last class about how to reduce the parameters and all that. Epinucleus removal, we have the Samuel Masket technique. Also, the epinucleus folds like a blanket. Okay, let's take a blanket, it folds. You can use high vacuum, low Phaco power, and can have your low aspiration flow rate as well, moderate aspiration flow rate. You can use what is called the flip technique or the trimming technique. The flip technique is a little better. The trimming technique, sometimes if you don't get an edge, then you'll have a problem. This is a flip technique wherein you can go here, right underneath the anterior capsule. You can see that edge of the epinucleus will come up near the anterior capsule and try to pull it. If you try to go towards the posterior capsule, there is a possibility that you may touch the posterior capsule and you can have a problem of epinucleus. I'll be showing some videos on also. This is an epinucleus mode. All the machines have got what is called epinucleus mode. What is this epinucleus mode? I don't use this epinucleus mode, but I would suggest that for all beginners, go for the epinucleus mode. So there is a Phaco 1, Phaco 2. Sometimes you use Phaco 3 also. It is hyperpulse or whatever it is. Many times you use that. Then when you remove the nucleus and when you see an epinucleus, go for the epinucleus mode. The epinucleus mode is nothing but the vacuum is less. The aspiration flow rate is less. Instead of asking your assistant to reduce the vacuum, reduce the flow rate, automatically you just press that button of epinucleus mode. In any machine, it is available. So the AFR in a peristaltic machine, the AFR comes down. The vacuum also comes down. In a Venturi system, automatically the vacuum in the Stellaris I use of normally about 450 to 600. In the epinucleus, when the epinucleus comes, I'm bringing down to 250 because you don't require much vacuum. You don't require much holdability. As I told you last week, the holdability of the nucleus is directly proportional to the vacuum. So if you want the holdability, especially for chopping, you need holdability, you need more vacuum. For epinucleus, it's not a very hard one. It is only between the nucleus and the cortex. It's relatively soft only. You don't require holdability. You just have to catch it. So catch it, you need a fairly good vacuum. We don't use very high vacuum. About 250 millimeters of mercury, that is good enough. You can see in a Centurion system, they have advocated 525, but it is also all linear. But you see the aspiration flow rate. Normally, I keep my aspiration flow rate 50 ml or 60 ml during the nucleus removal. But when I am removing the epinucleus, I don't want the posterior capsule to come fast into the port. Please understand the aspiration flow rate, as I told in the first class, the aspiration flow rate is directly proportional to the followability of the nucleus. Okay? Non-target tissues like the iris and the posterior capsule can also come into the port very fast if you have an high aspiration flow rate. So when you have an epinucleus, Under the epinucleus, nothing is there. Straight away, it's a posterior capsule, minimal cortex. The cortex is not going to prevent you from rupturing the posterior capsule. So you have to be a little careful. You don't have to have good speed there. Just hold the epinucleus and bring it up. So you can see this is a vacuum I'm using in a Venturi system, and a hyperpulse. You can use hyperpulse, or you can use a regular pulse, whatever you're comfortable. You can see here, I'm trying to do the flip technique, and automatically I'm just staying in the center. The advantage of the Venturi system is that it comes automatically. Okay, you don't have to. In a peristaltic system, sometimes you might have to occlude it. You can see here, I'm going there, I'm going there. I'm not going too much to the periphery, underneath the capsular rhexis margin, and then trying to increase the vacuum on the foot switch, the linear foot. That's a very, very simple method. You can see here is again the nucleus and the epinucleus coming along with that. Nothing is there. You can see the posterior capsule is bare there, and only the cortex is there in the periphery. So you have to be a little careful when you're doing that. In Venturi system, I don't reduce the parameters because chamber is so stable. You can see this again, just to show you the iris hooks, how the nucleus, the epinucleus, I'm just picking it up right in the center, and very easily you can see that it happens. You have to be very good on a foot switch. You can see there's a posterior polar cataract. I'm trying to remove the epinucleus. Watch underneath there. What is happening? There is a posterior capsule tear underneath. Okay, you have to be able to see. You can see how the tear is enlarging, and then I'm injecting viscoelastic through the side port. When your tear is enlarging, whenever you see a PC tear, don't pull out of the eye. Always inject viscoelastic there. This happens very commonly with posterior polar cataracts. When you try to remove the epinucleus, the posterior capsule can open up. So what are the parameters? Power is about 10% of the pulse, or hyperpulse, reduce the pulse, reduce the Phaco power. You don't require much Phaco power. Epinucleus is a very soft thing. Vacuum, as I told you, 200 to 300 millimeters of mercury. Normally, whatever vacuum you're using for the nucleus, that you make it about 2/3 or half of that for the epinucleus mode. Or go for the epinucleus mode, which is available there in the machine. Now let's come to the cortical aspiration. The cortical aspiration in Phaco is different from the ECCE because there's less cortex to remove. Closed system helps to maintain the AC depth, and the continuous curvilinear capsular rhexis eliminates capsular flaps, which is there quite commonly seen when you do a beer can capsulotomy or can opener capsulotomy. The advantage of the capsular rhexis is that there are no capsular flaps. Whereas if you have a can opener capsulotomy, there can be capsular flaps, and every time you use a SIMCOE or a IA, you can pull the anterior capsule. By pulling the anterior capsule, sometimes you can tear the anterior capsule also, or you can pull the equator or produce a zonal dialysis, or the tear can extend posteriorly, producing a posterior capsular tear. The stage 4 stages I advocate as far as the cortical aspiration is concerned. One is seeking occlusion, then grasping of the cortex, gentle traction, and removal of the discharge, bringing it to the pupillary area, and then increasing the vacuum. Okay, I will show it in a couple of slides. More important than that, any stage, whether it's capsular rhexis, wound construction, nucleus management, but more importantly, in a cortical aspiration, you have to see well, where is the anterior capsule and where is the posterior capsule. And the bag has to be inflated with a viscoelastic. I prefer to use something like Hyalon, but Hyalon everybody cannot afford. It's not advisable also. You can use simple HPMC. Only thing is, you need to inflate the bag. Why you have to inflate the bag? Because the anterior capsule has to be separated from the posterior capsule. Unless you inflate the bag, the capsular is very, otherwise, every time you catch the anterior capsule, the posterior capsule will come forward. Because you're using very high vacuum, you are likely to rupture the posterior capsule as well. Comfortable focus and magnification, very important. regularity of hydrodissection, which I have talked about already, maintenance of the anterior chamber. So either of the fluid, because you don't want the fluid to leak out, or by means of viscoelastic, appropriate IA and vacuum. Okay, so these are the things. So comfortable focus and magnification, very important. There are three ways by which you can do the cortical aspiration. The automated IA handpiece, or you can use a bimanual automated IA handpiece or a coaxial automated IA handpiece, or you can use a manual SIMCOE. I would not suggest a manual SIMCOE, but there are some Phaco surgeons who are preferring manual SIMCOE because they feel more comfortable and because they are not very confident on the foot switch, and because they are used to the SICS and whatever you are comfortable, that's not a very, very big thing. I'm going to show you all the three. This is a coaxial irrigation aspiration. Okay, coaxial irrigation aspiration means that the irrigation and the aspiration are in the same port. That is what is important. The coaxial irrigation aspiration. This is what I use regularly. Okay. In special situations, which we will talk about, then I will switch you out to bimanual IA. This is a bimanual IA. Bimanual, whichever company, whether it's Duet, Appasamy, so many companies are making it. That's not a problem. Bimanual IA means you have to use two side ports. Okay. The irrigation is separated from the aspiration. This is very good for beginners, number one. This is also very good for you to access the 360 degree of the fornices in the capsular bag, and especially subincisional cortex, you can use it. This is the only thing which you have to use in the case of a PCR or when you are dealing with the posterior polar cataract. Okay, so this is the only thing. I will tell you why. This is a SIMCOE wash. You can see a SIMCOE wash. I'm going through the main port. I'm going. The problem with this SIMCOE wash is that it's a very safe technique, but only thing is, again, the chamber stability is not guaranteed. See, you can see here, the chamber, you have to keep on filling up with viscoelastic. Then sometimes you can go to the side port like this and access the subincisional cortex. And SIMCOE is a little bulky, so you have to make sure that you have a good, bigger side port for that matter. Make sure that the side port closes properly at the end of surgery. So you can see here accessing these things. Everything is done with the hand. The control is done with the hand. It is not done in the foot switch in SIMCOE because the syringe is there in your left hand. Then you go in and this thing. Many surgeons still do that and they are very comfortable. I'm not against it, but there are definitely better methods of doing it. Now let's see how the cortex aspiration. What are the parameters you use? You need to use a little more vacuum, 400 millimeters to 500 millimeters. And can have a linear vacuum. Why I'm saying linear? Because you have to see and then increase, okay, the vacuum. So when you are just occluding at that time, you don't require much vacuum. When you bring the cortex to the center, then you increase the vacuum on the foot switch. It's like doing it on the accelerator on the car when you want to. So you see when the road is empty, then you increase the speed by pressing the accelerator. Of course, AFR, don't keep the very high AFR because you don't want rapidly the things to occur. So everything occurs in a little slower motion. You can see here, this is a curved coaxial irrigation aspiration. I always tackle the subincisional cortex first. This is a thing I have learned from Bobby Osher. It's really a fantastic. Why the subincisional cortex first? Because when the bag is open, it's easier to remove the subincisional cortex. The bag is open. The bag is open when the cortex is there all around and you're filling with the viscoelastic, especially with the viscoelastic, cohesive viscoelastic. Then it makes the bag a little open, and you can see here the subincisional cortex is I'm removing the cortex. What I'm trying to say is, you can see here how the port is facing sidewards or the port is facing up. I'm catching the anterior end of the cortical fiber and catching it there and then pulling it towards. You can see sweeping movement. You can see I'm doing a sweeping movement there, pulling toward. I'm not having increased vacuum there. No, I'm pulling it center and then increasing the vacuum. How do you increase the vacuum? You just have to make sure. You can see this is a sweep wash technique which I have described, and you can see here I'm going underneath the subincisional cortex. You can see here, first 12 o'clock. That is 12 o'clock means wherever you are sitting is 12 o'clock. Yeah. You can see here, this is a sweep wash technique. I go clockwise, and you can see there is not only a cortex but also a little thick epinucleus also. And going clockwise, and then you can see the port, how it's facing. It's facing me or facing sidewards. It's never facing the posterior capsule. Very important again. And then I'm going anti-clockwise. You can see here, I'm going again anti-clockwise and then removing the cortex. That's all. So it's one stroke, one sweep wash on one side clockwise, the other side clockwise, makes life easy. You don't have to go in and come out, go in and come out every time. Again, just to show you another video, keep on seeing videos like this, then makes life easy for you. You can see here, I'm just going subincisional cortex and going, and can see here, as I'm bringing it to the center, I'm increasing the vacuum, and never my port faces down. You can see here, never, always sidewards or upwards, and never my port faces. You can see here, I am always able to see the port. If you are not able to see the port, the opening, that means that you are in danger. Please understand that, because you can catch the posterior capsule and within no time you can rupture the PC. So clockwise, anti-clockwise, that is a sweep wash technique which makes life very, very easy. Start again, subincisional, curved. I use a curved one because it makes life easy for me. You can use a straight one also. Many people use straight ones also. Doesn't matter. For me, curved ones, whatever you're comfortable. Doesn't mean, I'm just giving you the basic principles. Whatever you're comfortable, you can use it. You can see that the subincisional cortex, I'm trying to remove that. Whenever I'm trying to remove that, please understand that I'm always catching only the anterior edge of the capsular fiber. Please understand this. Never the posterior. If you want to catch the posterior, suppose there's no anterior edge, go for the cap work mode and then try to catch the posterior edge. Not use the regular IA mode. So just to show you that, so you can see the posterior polar cataract. This is the posterior polar cataract, and then I'm doing the, I don't want to show all these things. You can see here, and this is what happens in posterior polar cataract. See, I'm trying to remove the epinucleus. You can see that epinucleus, you can see the plaque on the back of the epinucleus. As I'm removing the epinucleus, you can see what is happening there. And that is a big tear. This is the pre-existing tear. It is not a tear which is being created by you. Once I see that, I inject viscoelastic and come out and go shift to BIMANNUAL. This is an indication for absolutely 100% indication for a BIMANNUAL IA. Always remove the vitreous which is there, use tricot and then remove the cortex. If you try to remove the cortex in the presence of vitreous, then what will happen is every time you remove the cortex, the vitreous will get what you call that, can be vitreous traction. Postoperatively, the patient can develop detachment of the retina, breaks in the vitreous base, and all that. So you can see here, every time I come out of the eye, you can switch. That is the advantage. You can see the two tears on the posterior capsule. That is the two pillars on the posterior capsule. Very, very typical of the posterior polar cataract. And this implantation and the technique and all that is beyond the scope of this lecture. You can see this is a BIMANNUAL IA. Very, very simple. You can see here, BIMANNUAL IA. What is the advantage? I can use both the hands there. I can use both the hands and try to stuff that cortex or the epinucleus or whatever. You can see here, I'm accessing that subincisional cortex. The chamber stability, you don't have to bother at all because the chamber is always stable. You are having an irrigation on one side and the aspiration on the other side. You can switch from the right and left hand. Of course, all the phaco surgeons are now ambidextrous. They can operate with the left hand, they can operate with the right hand. It's not difficult at all. So you can see here, I'm switching from the left and brought the irrigation to the left and then aspiration to the right, so that I have an axis of 360° of the fornix of the capsular bag. So that is the advantage of the BIMANNUAL. More importantly, the chamber is stable. As long as the chamber is stable, you don't have to bother about the posterior capsule coming forward. As long as the posterior capsule doesn't come forward, you don't have to bother about the posterior capsule rupture at all. So that is the advantage of the bimanual thing. So you can see here, these are the do's and cortical aspiration. You can see here how I'm doing that. The port is facing me, and always hold the anterior edge of the cortex, strip, grasp, pull, and increase. Grasp, pull, and then increase the vacuum. Don't increase the vacuum at that time, not there at this time. You can see here, grasp, pull. You can see the anterior edge and the posterior edge, and all these are there for you to understand this. Again, subincisional cortex. So many people ask me, you are using coaxial. Yes, subincisional cortex, sometimes it's a problem. As I told you, I follow this, just to show you this video, how this the video can see here, the port has to face you or the port has to face sideways, never the port like this. Just to show you all that never, always port has to face you or sideways. You can see here, I'm trying to do the sweep wash technique here. Again, a patient with the small pupil iris hooks I've used. I'm trying to remove the subincisional cortex, but I'm not able to remove, so I'm going around. No problem, because the subincisional cortex sometimes can be very sticky. What do? Either if you have a bimanual, no problem at all, but I don't use bimanual routinely unless it's, as I told you, when I have a problem like a PCR or a PPC or something like that. So you can see here, this is a subincisional cortex is still there. I'm trying to remove that. You can see here again, that is the posterior edge. So this is the posterior edge, and this is the posterior edge, and this is the anterior edge. Never catch the posterior edge. The subincisional cortex is still there, and then you can leave it like that and take it later. Take it later means post-implantation. That is what I'm going to do. Don't try to catch that subincisional cortex or try to remove it. You'll end up in a PCR. Most of my beginners, Phaco beginners, we have trained more than 650 people from all over the world, and they find out they try to remove the subincisional cortex and they end up in trouble. Okay, so this is the problem. So if you, some amount of cortex, this amount of cortex, you can actually leave it like that, nothing is going to happen. But very simple method, which I'm going to show you, is to say I'm trying to remove the subincisional cortex. Now I'm putting this lens. The lens is being put now. Then I'm just going so simply, beautifully it will come. The subincisional cortex, how much ever subincisional cortex. You don't have to bother about the posterior capsule because the posterior capsule is well protected by the lens itself. I hope you got this point. Subincisional cortex, you can use a side port cannulation or a bimanual IA, J-shaped cannula or a curved cannula, I say what I'm using. Iris retraction with the Kuglen hook, you can do it. Post-implant aspiration. If you have a message, post-implant aspiration, best thing. Fill up the IOL is there in the back. Nice cohesive viscoelastic. Go in and then stay in the subincisional area automatically the cortex. Otherwise, just rotate the lens. Rotate the lens, the cortex will get, sometimes the cortex is very sticky, subincisional cortex. It will come out very easily. Again, you can see here, I'm going around and then starting from the subincisional area, I'm going clockwise, can go clockwise or anti-clockwise, whatever you're comfortable with. But more importantly, you can see that the port, the chamber stability, grasping, and then you can see here catching that anterior edge and bringing it up, and then this thing. FEMTO, when you're using FEMTO, what is the problem? FEMTO, the problem is the FEMTO cuts the cataract like this. So you don't get that anterior edge of the fiber. So it's always very difficult to do a cortical washer. So I go underneath the anterior capsule towards the equator and try to catch the anterior edge. You can see here I'm going all the way underneath there and trying to remove that in the FEMTO. This is only a learning curve. Sometimes you can catch the posterior. You have to be very careful. You have to have good experience. As I told you, the message I will not give for beginners. Just to show you, when you have a plaque on the posterior capsule, sometimes when you remove the cortex, you can see here this is a posterior polar cataract in a young girl. As I'm removing the thing, you can see here, I am removing the epinucleus and the cortex. And you can see that I'm trying to remove the dense plaque which is there. Okay, you can't yak these. Okay, so you need to remove that. So I'm just trying to remove that. I'm using a bimanual technique. You can see that I'm trying to remove the plaque from the posterior capsule without damaging the posterior capsule. Going out with the SIMCOE lens, and the patient did very well for that matter. So what happens when you put a CTR? When you put a CTR, it blocks the cortex. Please understand. So the cortex doesn't come out because it traps the cortex. When you put a CTR like this, then your technique of removal of the cortex has to be different. How different? Because normally you pull it towards the center of the pupil. As I told you, the normal cortical aspiration, okay, without the presence of CTR or something like that, you catch the anterior edge and pull it towards the center of the pupil and increase the vacuum, making sure that the port is facing you or sidewards, as I told you. So I'm putting a CTR here and fixing that Seone ring to the sclera. This patient had an extensive zonal dialysis of almost more than 180 degree. Obviously, we had to use a Seone lens. You can do a bimanual eye. Let's see here, bimanual eye, if you do position, if you try to pull it radially, then the CTR will trap and you will not be able to remove the cortex. So what you have to do is you have to go circumferentially. Circumferentially, that is along the equator or along the capsule. You can see here how I'm doing it. Circumferentially and pull it out. Then the CTR becomes easy. Otherwise, you can even catch the posterior edge, but that I would not advocate. Go circumferentially or tangentially along the equator instead of pulling it radially. And once you come to a certain point, then you pull it radially, the cortex will come out. Cortical aspiration, the presence of PC tear, it's a different ball game. Viscoelastic technique, you can use, keep putting viscoelastic. Dry aspiration with the SIMCOE cannula, you can do that, but that takes a long time. Sometimes epinucleus will be there, and I would not, some people still do it. If you have a small amount of cortex, probably you can do that. Or, as I told you, you have to shift to bimanual eye. Do not use coaxial irrigation aspiration. If you look at this animation, you can see here, when you have a PC tear, there's an animation by Bobby Osher. When you have a PC tear, what happens? If you use coaxial irrigation aspiration, the PC tear will keep enlarging. And what is a small PC tear, like a 1 millimeter, 2 millimeter PC tear, will become a huge PC tear right in front of you. And more vitreous will get hydrated and come into the anterior chamber. Whereas when you have a PC tear, and if you have a bimanual means that the irrigation is separated from the aspiration. You can see here the bimanual, the irrigation on the anterior chamber maintainer tamponates the brake and also prevents the hydration of the vitreous. And whatever vitreous comes into the anterior chamber can be cut with the vitrector, and you can put a lens in the bag, and the PC tear remains the same. Look at this video very carefully. This is one of my Phaco trainees. What he is trying to do, the mistake he is doing is, he's trying to catch the posterior end of the fiber, okay, which is near the posterior capsule. See, this is a PC tear, and the nucleus is also sinking. A part of the nucleus, quarter of the nucleus is going, and you can see here, it's pulling it out. If you pull out, what will happen? The PC tear, as I told you, the coaxial irrigation aspiration, and you pull out the PC tear, what was a very small PC tear became a huge PC tear, and vitreous is like a tsunami. More and more vitreous will start coming into the anterior chamber. You saw the lens is also, the nucleus is also gone inside. So all these problems can occur. You can see what is happening in the bimanual aspiration in the presence of a PC tear. I'm removing the last piece, then a PC tear is occurring. Can you see the PC tear there? And you can immediately, I'm injecting viscoat. I don't have any financial interest. The viscoat will go and plug the PC tear. And slowly, I'm stabilizing the chamber, and slowly I'm withdrawing the Phaco probe from the eye. Then immediately I'm creating a right side port. And then see that right side port and going bimanual. Now the viscoat is tamponating the vitreous. Going bimanual, I'm having a separate irrigation. The aspiration is separate bimanual and trying to sink. Then I found there is also some vitreous there. At that time, a long time back, tricot was not available. So I just did an anterior vitrectomy and went ahead. But more importantly, the PC tear is the same. In the beginning, the PC tear was 2 millimeter. In the end also, it was only 2 millimeter. I was able to put a lens in the bag. At that time, MA60 lens was a video which is long time back, 18 years back. MA60 lens was put in the put in the bag, mainly because I was able to limit the PC tear because all the protocols I followed very, very strictly. You can see this is a bimanual IA in the presence of a PC in the posterior polar cataract. Always remove the vitreous which is there, as I told you. Then you can go in for the cortex or the epinucleus. Don't be in a hurry to remove the epinucleus in the cortex when the vitreous is there in the anterior chamber. Always put tricot. In this particular case, I didn't put tricot because the patient had a family history of glaucoma. That is the reason. But always put tricot. Why? Because vitreous is a colorless substance. Unless you put tricot, you will not be able to see the vitreous very clearly. Once you remove the vitreous, then you can go ahead and remove the cortex. You can change. And whenever you come out of the eye, inject viscoat like this. When you have cortical aspiration and you have a small pupil, for example, this patient has got an IFIS syndrome. As you know, IFIS syndrome, patients who are on alpha blockers, tamsulosin, can see here this is a patient, all of a sudden the pupil became very small after the nucleus removal and the cortex. Then I'm trying to aspirate the nucleus. I'm sorry, aspirate the cortex. But please understand, go in and try to retract the iris with the Y rotator, which is the second instrument which is there. If you're not, always look for the cortical remnants which is there. Sometimes even epinucleus and sometimes even nucleus will be there underneath. You can see here how I'm trying to go there with the second instrument acts like my second hand. You can see that second hand and going and extending it all round and making sure that you remove the cortex. You can see that another patient you can see here, again, a patient who had a small pupil, IFIS, on the table, all of a sudden the pupil became small, and you can see here, I'm retracting with the second instrument, which has got a Y rotator, like this. You can see here how I'm, quadrant by quadrant, every clock hour I'm going there and trying to pull. As I told you, the basic protocols, always make sure that the port is on the side or up, and then catch the anterior end of the cortical fiber, where because the pupil becomes small, you do not know where exactly your rexis is. So always retract, use your second hand, your left hand as a second hand, and something like a bimanual technique you have to do. The caveats is, never use ultrasonic tip for cortical aspiration. Do not face the port downward. Always stay below the rexis margin. Aspirate the anterior edge of the cortex. Bring it to the center and then increase the vacuum. Go in a clockwise fashion, always. So these are the things. But more importantly, one message I want to give that, do not be complacent. At the end of the surgery, you might have dealt with a very hard brown cataract or a posterior polar cataract, and you are very, very, very confident. And what happens is, you don't concentrate as much. And that is the reason for PC tear occurring during cortical aspiration, even for the experienced surgeons. So always make sure that your focus is good. You're able to see the anterior and posterior capsule. Inflate the bag nicely every time. And then whether you're using coaxial or bimanual IA, follow all these protocols very, very clearly. And I'm sure you will do very well as far as the epinucleus and cortical aspiration is concerned. Thank you again, J&J, for this wonderful opportunity. We'll see again next week. Being COVID, stay home, stay safe, stay healthy. Thank you very much. I'll stop sharing the screen now. Yes, sir.
Yes. Thank you so much, sir. It was such a wonderful, inspirational talk from a basic beginner to the expert. I think everyone should have seen this webinar. I'm really happy for all those people who have seen it. And for all those people who have missed it, we are going to have the link soon in Rajan Eye Care website and YouTube soon. A few of the questions which have come, sir, is, are you having a separate tip for PC polishing?
No. The PC polishing, the same tip you can use. Only thing is go for the capsule vacuum mode, okay? And sometimes what I use IA max. Only thing is if I have a linear, I know how much to control, but I would suggest for beginners, go for the capsule vacuum mode, or you can use just a cannula, okay? You can use a irrigation cannula, whatever you're using for the hydro. You can just wash the posterior capsule, or give a forceful jet of fluid on the posterior capsule, and you can use the IA to remove the epithelial cells. So the PC polishing, I don't use a separate. Of course, the separate cannulas, separate tips are available, but I don't use them.
Dr. Prashant was asking Prof capsule polishing curate. Prof, Kraff capsule.
Yes, it is there available, but I don't use it. You can use it, no problem.
Okay, sir. And does injecting Trypan blue reduce
sandblast cannula also? The sandblast also, you can use the posterior capsule polishing. You can do that. Sandblast cannulas used to be available. Even now it's available. You can polish the posterior capsule. You can polish the anterior capsule also.
Okay, sir. And use of viscoelastics for cleavaging the nucleus in posterior polar cataract. That more safer than hydro?
The visco dissection. Okay.
Yes.
And I would many papers have come out on that visco dissection. But basically, I would say that if you are able to do hydrodelineation, okay, and there are 5 important parameters which you have to do as far as posterior polar cataract. The posterior polar cataract, what I do is I make sure that I do these patients under peribulbar block. Okay, I make myself comfortable. I make the patient comfortable. The patient is high myope. I always do a parabulbar or a subtenon block. I don't do under topical anesthesia. Never make the rhexis, which is about 5 millimeter. Don't make a very big rhexis. Don't make a very small rhexis. Because 5 millimeter, because you want to capture the optic of the lens by putting the optic capture you can do. If you make it very big, then you cannot capture. Then do hydrodelineation only. Don't do hydrodissection. You can do visco dissection also. Do not attempt to rotate the nucleus. Every time you come out of the eye, inject viscoelastic. Use lower Phaco parameters and do the Phaco entire as a slow motion Phaco. So even while hydrating the wound, be careful, don't tighten the anterior chamber. Saying sometimes after putting the lens also, you can rupture the PC. The PC can open up. So these are the, I think, 5 or 6 points I would suggest. The posterior polar cataract. My video is there, posterior polar bugbear, on the YouTube. You can have a look at it.
Yes, sir. And in small pupil, you had showed amazing videos. Do you prefer bimanual over coaxial, as you can use one of the irrigation port itself to view the...
Yes. If you are, whatever you are confident of using. For example, I am used to coaxial irrigation aspiration because simple reason is I am a little lazy guy. I don't want to put another port, okay? I want to put less ports on the eye, okay? So because every time you put a port, you have to put left port and right port, as well as for the bimanual IA, and you have to make sure that these ports are sealed well, okay? And we are talking about it in the wound construction, how important it is to make sure that you put fluorescent at the end of surgery to find out whether these ports are leaking. Please understand, these corneal wounds are not as good as the scleral wounds. And even if there are micro leak, you can produce endophthalmitis. So I don't want to put too many ports. That is the reason why. So for me, a curved coaxial irrigation aspiration and a wire rotator, which is on my second hand, I'm able to do that very, very easily. So I'm sure if I'm able to do that, I'm an average surgeon. I'm sure everybody will be able to do that.
Age is just a number for you, sir. Dr. Niven had asked that question in small pupils, sir. So he was wondering.
Niven has got his own technique. Niven is a super guy, I will tell you. Niven is a super. I'm so proud of that fellow.
Yes, sir. And the second wave hydrodissection does it help before cortex removal in flax? The second wave hydrodissection.
Yes, flax, you have to be a little careful in hydrodissection. Please understand, in flax, what happens is the gas bubbles are already there. Certain amount of pneumodissection is already occurred. Okay, so you can do what I do normally in a regular hydrodissection. I do 3 quadrants. Okay, in a regular patient, what I mean, that is non-flax in a manual Phaco. Whereas in flax, I do only 1 or 2 quadrants because I know this nucleus is definitely because certain amount of pneumodissection already occurs. But I don't want to make sure very aggressive in hydrodissection in flax because you can have a rupture of the PC. So that is the reason why the 1 or 2 maybe waves in different quadrants in flax is also. You can see actually the gas itself makes a good amount of pneumodissection there.
True.
Yeah.
Thank you. Thank you so much, sir. I think these are all the questions and you have answered everything in videos. I think
I wanted your suggestions and your tips, Nishant.
I have already started with the bimanual irrigation aspiration. So as you said, definitely I have to put 2 side port. But one thing what I do is while I do it in the right side for my rexes, I do the full thickness. In my left side, because it is only the SIMCOE or the dialer or the chopper which is going to go, I do a small entry that is only allowing only the SIMCOE so that it doesn't leak. And just before my irrigation aspiration, I take. I feel that is one point which is very important if you're planning to do a bimanual irrigation aspiration. And as you said, I always and in cases of posterior capsular rent also I use the bimanual. And so I'm not having much of experience in coaxial. As you said, I'm comfortable, I am stable, and I have not even tried any other techniques, sir.
Fantastic. If you're comfortable with bimanual, continue with bimanual.
Yes.
Bimanual has got its own advantages. And so I'm very, the thing about it, I told you why I'm using coaxial, because we are all used to coaxial right from the beginning. When we started Phaco way back in '93, I think your dad was one of the earliest to start Phaco in this part of the world, actually in this part of the country, I would say. At that time, it was the coaxial irrigation aspiration which was available to us very freely, and we got trained in the coaxial. And subsequently, we got the curved ones and all that, and we made life easy. So then I learned this technique from Bobby Archer. And the sweep wash technique, which I have described, is very, very simple technique. So concentrate. See, the problem is what happens is when you do the coaxial irrigation aspiration, when you have the cortex all around, you have a temptation to go and remove the cortex from elsewhere. Okay? Don't do that. Always remove the subincisional cortex. Once you remove the subincisional cortex, then you go clockwise, then one sweep on clockwise on the left, one sweep on the right, then everything becomes fine. Okay.
You sweep washed everything, so it was so good, the sweep wash technique. And what about removing the remnant cortex? Like after you place the IOL, sometimes you see post-operatively there is some cortex behind which gets stuck, and on dilatation it is seen. When you go in for a secondary surgery, is there any tips and precautions when you want to do a re-cortex wash when the IOL is in the back?
Yeah, sometimes this can happen, and it can be very, very troublesome. And you can have cortex, which is subincisional cortex. That is why we don't want to leave too much of subincisional cortex. The subincisional cortex, because it's a closed bag, in ECCE it will come up because it's not a closed bag. Here it's a closed bag. The cortex will migrate towards the visual axis, going underneath the eyewear. So what I would suggest is use a good viscoelastic. You need to go in and do it. Here the bimanual works wonderfully well, because you just have to have the irrigation on top, go in, and underneath the lens, you can just make sure that you have a good cohesive viscoelastic to expand the bag nicely. So you can do it as early as possible because you don't want to have much inflammation. So especially when it's the visual axis, you can't even yak them. There's a big problem. Sometimes it forms something like a sheet. I've seen some patients, coming to refer to me from outside, and they say it's like a sheet of cortex on the posterior capsule. Sometimes if you don't have a good microscope, then there'll be a small thin sheet on the posterior capsule, which you may miss completely. Okay, you think it is a posterior capsule there, it can be a very thin sheet. But post-operatively, we see that it's happened to me long time back. Okay, when I was using the Ascon microscope the Indian, one of the oldest microscope at that time. I'm talking about 20 years back, 25 years back, when I was operating elsewhere before the Rajan was started. So at the beginning of the Phaco emulsification, before 1995, this happened to me. So what I'm trying to say is you need to have a good microscope. Last week, somebody was asking which Phaco machine to buy. I said, Phaco machine is not a problem. Any Phaco machine is fine. But have a good top-end microscope. That is what I would advise everybody, because you need to see well for you to operate well. Everybody has got the same technique. Everybody has got the same technology to a certain extent. But the microscope is different. The microscope, if you have a lower-end microscope, you can operate with a lower-end Phaco machine. No problem at all. I'm sure you can do that. Nivian can do that. I can do that. Everybody can do that. Okay. But if you cannot operate with a lower-end microscope, am I right or not? Okay.
True, sir.
Yes. You need to have a higher-end microscope. You need to see well. You need to have a good zoom. You need to focus from the anterior to the posterior capsule. You need to know exactly what is happening. Okay. Why people are having a problem with the small pupil? Because they are not able to see well. Okay, that is why I'm saying small pupil, right at the beginning, use iris hooks or Milligan ring or BX ring, whatever is comfortable. Because if you operate on a small pupil, okay, these are all cases I showed you because these pupils were okay in the beginning, but became small during the cortical aspiration. What do you do at that time? I cannot put iris hooks at that time. So you need to go in and aspirate the cortex by using all these techniques. But what I'm trying to say is, if you cannot see well, you cannot operate well, and you are bound to produce all complications.
Yes.
So that is the take-home message I want to give as a person who has been in this practice for almost 30 years now. I want to give the golden message: buy a top-end microscope. I don't mind telling the name of the microscope also, Zeiss or Leica or whichever this thing is the top-end microscope. That's what it is. Yeah, yes. Moller, Wedel, whatever it is. Yeah, but Zeiss is what you invest in a good microscope. I think your game is over. That's all. Sure. Whatever machine is fine.
Exactly, sir.
Yes.
Thank you so much. There's one more question is, what if there is a PC plaque? Do you prefer intraoperatively removing it, or if it is adherent and stuck, what do you want to yag it later?
Absolutely. If it's a plaque, very big plaque, as I showed you, and that's why I showed that particular video there. Young girl, you can't yag these plaques. Okay, if you try to yag these plaques, you'll have to use very high energy. You can produce pitting of the lens. If you have high energy, you can produce detachment of the retina, and so many things are there. So I would do, very easy to remove these plaques. Okay, you just have to create a nice cleavage. It's like removing the membrane from the retina, epiretinal membrane, similar to that. Okay, membrane peeling. Okay, Nivian will know that. Okay, better because he is doing vitrectomies regularly. So if you have a BIMANNUAL one, you just have to hold it, create a nice cleavage plane, and you can remove these plaques very easily without damaging the posterior capsule. Okay. Or if it's a slightly lesser dense plaque, if it's a mild plaque, then you can probably leave it, you can probably yag it up. But most of the plaques, I try to remove it on the table. Sometimes I do even a posterior capsulorhexis, okay? And don't attempt to put a lens in the presence of a posterior capsular tear, because the tear will enlarge. Always convert, if you have a small tear, convert that into a posterior capsulorhexis, and then go ahead and put a lens.
Creating the cleavage, you use any spatula or anything?
Just viscoelastic, like Hyalon. The Hyalon creates a cleavage plane, and then you just have to pull it up and inject Hyalon, pull it up with your left hand, pull the plaque up in the left hand, then there will be a space between the plaque and the posterior capsule, okay? Okay. And similar to the posterior capsulorhexis, when you're doing posterior capsule in pediatric cataracts, what you do is you just put Hyalon in that space between the posterior capsule and in the Berger space on the anterior hyaloid. You don't want the anterior hyaloid, you don't rupture the anterior hyaloid. You can do that similarly. So similarly, you just put Hyalon there. The Hyalon creates a nice, beautiful cleavage plane there. Pull it up, and then you can have an edge. Once you get an edge, it's very difficult to peel off these plaques from the posterior capsule without damaging the posterior capsule, as I showed in that video.
Yes, sir. Amazing it was. And just regarding the cortex, is there any amount of cortex which we feel it is okay to be left behind? We see postoperatively, there's a small cortex, fluffy cortex, eye is quiet, vision is 6/6, patient happy. We still want to remove it, or is there any?
Depends on where the cortex is. The cortex is there in the periphery. You can just leave it like that. Nothing is going to happen. Or the small cortex is there in the anterior chamber. It will get absorbed. Nothing is going to happen. If the cortex is there in the behind the lens in the pupillary area, then you have to go in. Okay. But if
Yes.
my suggestion is you see nowadays we have got excellent instrumentation. You have bimanual, coaxial, you can have everything, J-shape, straight, and whatever, curved cannulas and all this. Try to remove the cortex almost 100% of the time.
Yes.
100% of the time. Especially in small pupils, you'll be shocked or even surprised to see that. Small pupils, because sometimes the cortex will be hiding underneath the iris. You are not seen it, you are not examined it before, after implantation of the lens. You have to go around, examine it all the way to the periphery. You have to see. Sometimes these cortex will migrate to the center and they will make your life miserable.
Thank you. Thank you so much, sir. So,
Thank you very much. Nishant.
yes, sir.
Nishant and Nivian and Shruti and Pratibha also. I have to mention them because without Shruti and Pratibha, and I'm not sure whether Nishant and Nivian would have come to this level.
Agreed and accepted, sir.
No. Yes, absolutely. No. The support they've been given, similar to what Sujata has given me. Without Sujata, I'm nothing. So it's the same thing. And without Shalini, Madhi is nothing. So I know how much of work Shalini and Madhi, when they started the work, how, what do you call it? No, there's no substitute for hard work and effort. And Madhi and Shalini were perfect examples of that. And every time I see Madhi and Shalini, I thank them for that. Yes.
Thank you for teaching us, giving you all the valuable tips, sir. That's the best thing. You're given the tips from the minute things to see till the macro things to see. And as you said, what you don't see, please don't operate. That is one amazing tip which you said, sir. Thank you so much. Thank you, J&J, for giving this opportunity. And final few words.
Yeah, I think I have to thank J&J and Nishant. Raghu and Ashok, are you there?
Yes, sir, we are there, sir. Thank you. Thank you to you and Dr. Nisha. Thanks a lot, sir.
Thank you, Raghu, Ashok, Jashwinda, and entire J&J team for this organizing this, again, the Phaco Masterclass series. It's always a pleasure to be here, and we'll see you again next week. We'll take a commercial break now.
Looking forward. Thank you, Raghuram, Ashok, Jashwinda, sir. Thank you. Bye, sir.